You see my screen now?
Yes. Yes. Yeah, that probably looks better than what I have sent to me.
I'll start at the bottom and we'll work our way up.
All right, perfect. It's the way to go.
Do you see those films?
Yes, that's perfect. And we see the lines now too, so.
All right. How clear are they?
They're actually very clear.
Okay.
Yeah. So we're good to start whenever you want, Doc.
Okay. All right, so what we're going to try to do tonight, guys, is try to look at some true full spine films and try to then apply, our thought process of what you would do with a real patient. Unfortunately, I don't have the histories with these films, but I thought what we would do is just kind of go through together, looking at them, and then as you're looking at them, just try to formalize in your mind what you're seeing, looking at the overall curves, looking for any pathology if one happens to pop up or something that you're wondering about, a shadow on the film. Talk about curvatures. We can even, try to guess possibly what this patient might be having going on based on what we see on the film. I noticed too that the doc that took these films put BBs on the film. So what I don't know is, are those BBs on where they think there's a break, or are those BBs like on a skin blemish, like a freckle or a scar? But since most of them have quite a few BBs on them, I'm going to go out on a limb and think that they are trying to mark a break. So in other words, they scoped the patient before they took the X-ray. They put BBs on where they thought they got the reading, and then now you have the X-ray to see exactly what disc level that reading might be at.
Dr. Meisel, are those white dots all the BBs?
Yeah.
Okay. I want to clarify that so we all know what we're looking at.
Yeah, so you see my arrow?
Yeah.
Yeah, so there's a BB there.
Now, you said you use different size ones like we see here for different things sometimes.
Yeah, there are docs that do it that way.
Like one may be a break, one may be for the skin blemishes like you were saying.
Right, so maybe the bigger ones are the breaks and the smaller ones might be a freckle or a scar. It's just hard to say. I don't have any notes.
Okay.
Okay, so just a couple of introductory things on x-rays. So if you're going to take full spine x-rays and you want to do it as close to how Gonstead wanted us to do it, you're going to take the A to P in one shot. You're not going to take it in two shots. You're going to take it in one shot. So to be able to do that, you have to have split screens in your cassettes, and you have to have a filter on your collimator so that you get a nice homogeneous view. Now, you can take the A to P in two parts and have stitching, but sometimes that can be confusing. I'm putting that together and knowing exactly what vertebrae you're on, especially in that transitional area. Also, the A to P should be taken at 84 inches, not 40. 84. And the 40% rule, if you're going to use that for calculating AD and MD, that 40% rule is based on the diverging rays at 84 inches. So if you get set up digital and you're not at 84 inches and you're at 60 or 40, whatever your room will allow, you're probably going to have to talk to your technician and find out what kind of tube tilt you're going to have to put on your on your tube when you take that lower half of that A to P. We don't mention that too much in school, but I think you guys should know about it, because I think if you're listening here at Pitt, then you're pretty serious about doing things as close to how Gonstead taught him, so that we can come up with the same results as he did.
Hey, Dr. Meisel, I've heard Dr. Justin Harris talk about doing, like, to get as close to 84 as possible, doing like a 15-degree, I think, cephalic tube tilt. I think that tube tilt may add that difference in distance if you can't get the x-ray itself all the way out to 84. Have you heard him talk about anything like that?
Yeah, so I'm wondering why that's cephalic tube tilt, because...
It could be caudal. There's a tube tilt, I think, is how they get that extra distance.
Yeah, because, you know, when you take it full spine at 84 inches, the x-ray beam is diverging down, right?
Right.
So you would think they'd have to have a caudal tube tilt.
Okay,
But
maybe it is. I couldn't remember. I think there's like a tube tilt is how he gets that distance. I don't remember exactly what.
Right, so you're going to have your x-ray tech help you with that?
Okay.
Dr. Meisel.
Yeah, go ahead.
I also was able to talk to, because Brittany and I are trying to figure out our x-ray system for when we open up. And I was asking the tech about the different, how the distance affects the film. And the tech was saying to me that the way digital works now, the way that they are able to, I guess, get the image projected, it doesn't matter what distance you shoot it at, it comes out at a certain, like, it'll come out to the standard, because they said they work with a lot of Gonstead docs, and they said that it ended up properly coming out to the standard that it wanted. I don't know if he knew that it was meant for 84 or not, but he was saying that you can shoot it at whatever distance, and the way it worked would actually get the proper magnification and stuff.
Okay.
I just didn't know if you've heard about that for digital. But
Well, I thought they had to do a modification with tube tilt, so like what Stephen was talking about.
yeah, I was interested because I was asking about it, and the way he made it sound like it was fine. And he has like a Gonstead doctor in the company that helped make this happen. I don't know. I'll probably have to investigate more, but that's what I heard about the digital for that company, at least. So,
Okay. You know, a doctor who recently just got digital, who is more old school, that would be Dr. Zakowski.
Mm-hmm.
And he's had his now maybe for 4 or 6 months.
okay.
So we can always ask him, you know, what he's done.
Yeah.
Yeah, he'll be coming down in the beginning of November, so we can bring that up.
Okay. And maybe even we can ask Dr. O'Hara. I don't know if he has digital or not. I'm thinking he probably doesn't.
So I think that Dr. Dan Lyons is the one that came up with the tube tilt.
Yeah, I've heard that. Is that Brianna?
Yeah.
Yeah.
Paul asked him at the extravaganza, and he said he measured it out, and it was 12 degrees cephalic. But then Robert White did it on a dry spine, and he didn't notice any difference. So he doesn't do it, and he shoots his at 60.
Interesting. Okay. Yeah, we should find that out so that we can be consistent with the information that we tell people.
Yeah. Because I also don't know how much this X-ray tech knows too much about the actual clinical part of being the doc,
Yeah.
opposed to
So-
just being an X-ray tech.
So Brianna, you're sure it was cephalic tube tilt?
Yeah, 12 degrees cephalic, I'm pretty sure.
Okay. And that was at 40 inches?
I don't know what Dan Lyons does, but I know Steven Barger does it at 60 as well, and he does the tube tilt.
So when you take a sectional A to P sacrum, that's at 40 inches, the way we teach it at school, it's cephalic tube tilt, but that's because, you're the sacrum is curved that way. and that X-ray is taken for a totally different reason. So I am curious.
Oh yeah, for sure.
I'm curious about the physics of it. So,
Marcos, it might be in the Gonstead Chiropractic Facebook group. I feel like I've seen people talk about it on there, so I would check that.
Yeah, thank you. Definitely. And Doc, I also found the X-ray, some histories in some of the files I got. So if you do want to go to those eventually, I have some histories with it as well.
okay, so this out of my files that I have.
Out of the files that I got sent, I was looking through them, and then a few of them had a history.
Okay.
So if you want to go to ones with a history, we can do that as well whenever you want.
Okay. Well, let's just maybe go through a couple of these first, just to kind of get warmed up, and then we'll try to look at one with the history. How's that sound?
That sounds perfect. Sounds good.
Okay, so I'm just going to move the film around and have you just kind of look at it with me, and I'll just try to talk you through what I'm thinking about as I'm moving around, and I'll use my pointer to kind of emphasize what I'm talking about. So, of course, you always want to look for pathology. And there's a couple different ways you can do that. You can just put your mind in the mindset that that's what you're going to do first on both films, or you can do it along together with as you're just trying to get an overview look of the film without drawing any lines. In fact, I wait to draw lines until I've really overlooked the whole thing, ADP and lateral, with my eyes before I even start to draw lines, because I don't want the lines to influence what I'm thinking about what this patient needs. So if you had to pick between the two views, what would be the most beneficial for you to help the patient? Most of you know which view that would be because we've talked about it before, but some of you might not. So those of you that know, somebody go ahead and speak up. What would be if you had to pick between the lateral or the ADP, which one? If Palmer said you could only take one of the two views, which one are you going to take?
Lateral.
Yep, the lateral. And why would the lateral be more important than the ADP?
Observe the disc
See them.
spaces in the disc belt.
And you can see which vertebra is posterior.
Yeah.
You can see visual posteriority. You can see the plane line of the disc. You can actually see also, I think, especially in the spine, if there is a pathology, you can see the pathology is better on the lateral view than you can on the A to P. So I'm just looking at that cervical spine, looking at the atlas and its relationship to the occiput, making sure the ADI looks normal between the anterior tubercle here and the dens.
Hey, Doc.
Yep.
If you had to choose one sectional, I would tend to go for the A to P pelvis so that I could get the PIAS measurements. What are your thoughts on that?
Well, those are two important measurements because that's really hard to visualize sometimes, that whether it's PI or AS, right? The INEX is a little easier based on the gluteal fold, but it's a little tougher for sure. But we're not gonna put ourselves in with one hand tied behind our back, right? We're gonna take what we need.
Thanks.
Yeah. All right. So it's up to you how you want to start. If you want to start from the bottom and then work your way up, or start at the top and work your way down. Just whatever it's going to be consistent. All right, so I kind of got an idea on the lateral. So based on that lateral, how old do you think that patient is?
20s, 30s.
So those disc spaces, to me, they look pretty good, don't they? Overall, they're pretty thick. I don't see any degenerative changes much at all. A little bit in the thoracic, but the cervical and lower back look good. So I would say in the late 20s, early 30s maybe. And then on the A to P week, on the pelvis, we can see that by the shape of the pubic area that that's a male. Do you guys see this line running through here? That I have my arrow on that. That's what we call the gluteal fold. And that's a good landmark to look at to decide whether or not you have good patient positioning on the film. To me, this looks like the patient might be a little rotated because that gluteal fold is a little bit to the left of that symphysis there. So you always want to watch that. Another thing to look at is look at the size of the lesser trochanters. Because if one is much larger than the other, then that could indicate rotation as well.
Wait, can you stop right there real quick? You said the greater trochanters, if one's larger, it's rotated? Or
The lesser.
lesser?
Yeah. I think it's easier to see on the lesser because it's close to the ischium there. You can see how you can look at that distance.
Gotcha, okay. So it'd be rotated an EX on the side that there's a smaller distance between those? Is that what you're saying?
Well, I don't use that to determine EX, but I know what you're saying. Yeah.
What did you mean by rotation? And I'm sorry, I got lost there.
Like their
Just their positioning?
their buttocks. Yeah, their buttocks isn't positioned lightly and level on that bucky, and they're a little turned.
Oh, okay, X-ray. So the X-ray position is off a little bit, is what you're saying.
Yeah.
Okay, I got you.
Yeah.
Doc, how do you know it's not their misalignment that's causing these changes as opposed to a rotated? Is that gluteal fold in the middle going to be in the middle of that pubic symphysis normally despite the ilium presentation?
I suppose anything's possible, but I really use that as a way of, it needs to be pretty close for me to trust it.
Okay, gotcha. Thank you.
Yeah.
Hey, Dr. Meisel, was somebody who's a little heavier set with extra adipose tissue and stuff, could that throw off the visual on that gluteal fold?
Not if you tell them, listen, Mr. Jones, I want you to take little steps back until you feel your buttocks just lightly touch that panel behind you. I do not want you leaning up against it. I don't want you, leaning one side of your body heavier than the other on that. I want you just lightly touching equally. So, I demonstrate to them and then I give it to them verbally. So hopefully the combination of that, they get it right.
Okay.
Another thing you can see too here is, look, you can see all of the left greater trochanter, but can you see all of the right greater trochanter? See how it's cut off here? So I don't think that patient's centered very well. See? See how the ilium on the right got cut off? You see all the ilium on the left? So that's another indication that that kind of goes with this gluteal fold.
Doc, do you see anything in that left femur head?
Yeah, I was going to tell you, initially I thought, the age of this person was relatively young, but now you look at these acetabulum and they look a little rough. So maybe this guy's a runner, possibly. Yeah, it looks like there's some degeneration going on in there, isn't it? Doesn't it?
What about at the top of the sacrum? It kind of, you see that white, kind of blackish, where that bead is? Is that
Right
calcification or?
Right here?
No, sorry, is that L5 then? Where that bead is. You see that like thicker, kind of white? Yeah, right there, like basically where you have your mouse on right there.
Okay, so what part of the anatomy of the vertebrae are we looking at there?
Lamina.
Lamina pedicle, right? So it just looks funny because it's missing the spinous here. We got a little bit of spina bifida going on here.
Okay.
And looks like too there might be a pars defect there on the right side.
Mm-hmm.
But it doesn't look like a spondylo on the lateral. See how the body of the vertebrae lines up to the sacrum?
Mm-hmm.
In fact, that disc looks pretty good, doesn't it? If anything, it might be a base posterior, maybe. But it might be normal. Now look, they've marked something here. And what's interesting about this BB is that look where it's at in relationship to the disc plane of L5S1 and the disc plane of 4-5. It's like right in the middle. So if I was the doctor and I'm the one that made that mark, I'm wondering, why did I think the reading was there? Because I'm either marking it too early or too late, because I'm not hitting the disc plane. See that?
Mm-hmm.
So if it's coming from 4 or 5, that BB should be about right there. If it's coming from 5S1, it should be about right there. Would you say this lumbosacral angle is a little hyper or hypo?
A little hyper.
A little hyper, yeah. So when you see a hyperlordosis at L5S1, what would you be thinking about?
EI, EX, maybe a tubercle.
Yeah, those two things, right? A PIX would do that, or possibly a tubercle, and it looks like there's a possibility right here. And here's another BB, so maybe that's a break that they're picking up down here.
Doc, I heard Dr. Wood say one time that a base posterior could make a hyperlordosis. How does that make? Did you see that, or was it hypolordosis? Did I miss it?
So all of that is compensation, and so it kind of depends when the spectrum of time you take that film on that patient, how long they've had that. Does that make sense?
Yes.
Yes.
Thank you.
Yep. So let's just kind of formulate some stuff here. Based on what you see on the width of the iliums, we'll just assume that we're going to trust the film, that it's not malpositioning. But we can't see all of the right ilium. It's been cut off, so we're going to have to rely on the obturators. So based on the obturators, which side would be the EX side?
The left.
The left, wouldn't it? So, and we try to find that first or second sacral tubercle to draw that sacral center line, and on the EX side, it would be like where this gluteal fold would be going through, right? That line should go through the EX side of the pubic bone.
Mm-hmm.
Okay, so we're thinking we have an EX on for your left ilium, but would we list the left ilium? Because don't we want to list the side of what?
Body rotation.
Body rotation, right, of L5. Well, L5 is pretty funky here, right? Can't really trust what L5 looks like because it's missing its spinous, isn't it?
Mm-hmm.
So what are we going to use then to help us figure out what L5 is?
O4 or the sacrum.
We can look at L4 and we can look at the sacrum. And remember, the sacrum, we measure from that sacral tubercle out to the lateral margin of the SI joint, the sacral part of the SI joint. And then we can look at the pedicles or the facets, the inferior articulating facets, and look at them to see how they look. So we'll see how the lines come out when we switch over to the other film. But look, something is creating this patient to pull that lumbar spine over to that upper lumbar spine over to the left.
Doc, can you quickly go over what would bring the vertebra over to the left? Like what possibilities there could be that would cause a scoliosis that isn't congenital?
Well, it could be a rotated sacrum. It could be an ilium, pulling it over on that side, especially like an EX ilium, pulling things down.
Okay, so it would pull things towards the EX or away from the IN pretty much. But
Yeah.
it would go to, okay.
As far as AS and PI, looks like obliquely that obturator is longer on the left, doesn't it?
Yeah.
So maybe it looks like maybe that left ischium is a little lower than the right. But it's also lower at the top, so we'd have to get an actual measurement. All right. What are we
Dr. Michael,
thinking of? Yeah.
If you see the entire ilium on one side lower than the other side, could that be? Have you seen a correlation with maybe an anatomical leg length being shorter on that side?
Right. So here, let me zoom in a little bit. So if you look at that, where the sacral baseline would be on this patient, it's a little lower on the left than the right, isn't it?
Yeah, everything seems a little lower.
And maybe even that femur head is lower on the left than the right, which would kind of make you think, well, the sacrum is just lower on the left because the femur head height is lower. But we don't know. We haven't figured out ADMD yet. But even though this is the low side of the sacrum, I wouldn't even think about putting a lift in this patient. Right? What are some of the other rules we have to remember about that?
Complete body rotation all the way up to C2.
I'm sorry, say that again?
Complete full spine body rotation all the way up to C2 on that side.
Right, but I'm talking about the heel lift. Why wouldn't we want to put a heel lift in this guy?
It looks like, is there scoliosis a little bit?
There is scoliosis, but which side is the low side of the sacrum on?
Concave.
The left and the scoliosis goes to the right.
Concavity, right?
Yeah, so if you put a heel lift, it would increase the scoliosis.
Yeah, yeah. And I'm not convinced that that's the side of body rotation of L5 either. All right, let's look at the dorsals. So we see some of this tipping is probably being caused by the sacrum being lower on the left. And we're just kind of looking up, looking for stacking. And right about there and there, so right in here, that's where it's starting to compensate. And look at 2 looks pretty posterior there. So I think if I was going to mark one posterior, I'd mark 2, L2 posterior. See how the disc is open in the front, closed in the back? And that one, can you get a listing off of L2? That looks like what? If you look at the pedicles.
PLI.
So it's PL, right? Because the pedicle is smaller on the side of spinous rotation.
Mm-hmm.
The pedicle is larger on the side of body rotation. You can almost see that whole pedicle there. And then the side of body rotation, that pedicle is closer to the midline.
The transverse looks tilted.
Yeah, look. So where the transverse and the body meet, you can see, and then just look at the disc space between the 2 M plates. There's a wedge on that right side, and then look what happens from 2 up. All that stacking. Now he's got a BB up here on, but that looks like T12, doesn't it?
Mm-hmm.
5, 4, 3, 2, 1, 12. There's our 12th rib. And I always numbered my vertebrae just because it made it easier to, when you keep looking at the film, to know exactly where you're at. $12 is a possibility. 12 is a possibility, but 2 looks more of a possibility than 12 to me. Because 12 looks like it's kind of in the middle of that stacking on the A to P. All right.
So, Doc, here's kind of a big question. So if you're getting your breaks at T12, but you're not getting a break at L2, you're more inclined to do that L2 right now if you don't get a break down at L2?
No, I want my scope to tell me more than anything. So then that's when you want to do some cambering, and that's when you want to do some extra special time with scoping it to make sure that it's not 2.
Okay. And if you actually didn't find anything at 2 in this case, you would think 12 is the one you're going for.
Yeah.
Okay.
12 or 1, actually maybe even 1. 1's posterior there too. Look at that.
Uh-huh.
You're usually never going to get in trouble by being lower, but you can get in trouble by being higher real fast. All right, do we think we have anything above L2 or T12? What are we looking for here?
Posterior wedging?
Posterior wedging, right? But we're going to have some natural posterior wedging just because we're in the middle of a kyphosis, aren't we?
Mm-hmm. What's with like the disc space? How come it looks like the end plates are kind of like bumpy?
Remember, you're looking at a lot of overlying tissue.
Mm-hmm.
So you got the ribs running through there. You're looking at the ends of blood vessels because you're in the lungs here.
Okay. I just wasn't sure if that was like
Yeah.
pathology or something.
Well, like I said, it does look like there's a little bit of wear going on this one. Let's see if we can figure out which one that one is. There's 7. So that looks like that's a T6. T6 and 7. So let's go over here. One.
Hold on.
So again, it looks like from about T7 up is you get all that stacking again up above it. So I'd be interested in this one, 6 or 7. They've got a BB up here. Let's get a listing. What do you think here?
That's definitely
PLS. Or
PR.
That'd be a PRS.
It's kind of in transition, isn't it? The one below it looks like PL, doesn't it?
yeah.
So it looks like things are starting to go the other way there. But then when you go higher up, they stay PL, and it isn't up until about T2. It looks like it might be PR, but that could be, looking at that bone, that could be malformed because T1 is PL, 7 is PL. So when you see them like that, I think you're right in saying PL. There's not much of a wedge on that. A little bit, so maybe PLS. How about his neck? What do you think of his neck? Just its structure.
Loss of curve.
Yeah, a little bit. But you know what? When you've been in practice a while and you see a neck that looks like this, that's pretty good compared to what's going to walk in your door. That's pretty good. I mean, yeah, we can say could be a little more lordotic, but look at the discs. They're pretty parallel, all of them. That one maybe a little posterior.
Could that just be from their head positioning when they take the x-ray, though?
Yeah, so they did something that I would never do. They collimated out the hard palate.
Mm-hmm.
But that's how you tell if the patient's looking up or looking down. So you instruct them to look straight ahead, and then you try to see that before you hit the expose button. But if the hard palate is angled down, that'll take the curve out. Or if the hard palate's angled up, that'll put curve in. So that is one way for positioning on the lateral, especially the cervical curve, you want to be aware of.
Could you tell from the AP? It looks like it's pretty flat there. Guess you know.
What's flat?
The palette on the A to P. Would you be able to tell there?
That's a totally different view, though.
Yeah.
That's a totally different view. As far as influencing the lateral curve, it would be if the head is tilted down or if it's tilted up.
Mm-hmm.
Doc, do you think there's an increased space between C1 and CO?
This distance?
Yeah.
Well, I can see the mastoid there.
Mm-hmm.
I think it looks all right. We see anything funny on the A to P up there?
All right.
If you had to do an atlas listing, what would be the first two letters?
AS.
AS, right? That atlas is sitting in an anterior superior position. You see any laterality?
A little bit. Is that the right?
Looks like on the right. So ASR, do we see any rotation?
The right disc base looks a little bit bigger, right? Or not the disc, but the
The lateral mass?
yeah.
You think it looks bigger? Okay.
No, the I don't know. I'm forgetting what it's called. Like the
Capsule?
yeah, the capsule.
So like the capsule height, you mean?
Mm-hmm.
And that's giving you the laterality, right? Is that what you meant by larger? Like there's
Yeah.
more of a space there?
Yeah.
So we're going to call it an ASR then, correct?
Yeah.
Okay, so is there any rotation with that? Do we have any A or P?
Say maybe A. Doesn't look like much, though.
Not much, does it? All right, so we kind
Hey,
of,
Dr. Meisel, does that left lateral mass look a little funky to you? Like
the left what?
the left lateral mass on the atlas there? Like the right one looks like the clear trapezoidal angle we're looking for, but the left one seems to be like a weird shape. Maybe it's just the overlapping
You get that
structure or something.
overlapping arch there.
Okay, it's just okay.
And this looks a little funky here, doesn't it? What could that be?
What's that?
Beginning of the posterior ponicle, maybe?
Yep, that's what I'm thinking.
Dr. Meisel, all the quarter nines are just trying to look for pathology on this because it's C9s.
Yep. So look at the heart shadow. Look at the apices of the lungs. Look at the ribs. Make sure the ribs are tricky because there's a lot of overlying tissue and what can look like a crack or a lucency is only because the bones are thin. Like this doesn't look very good, does it?
No. Not at all.
I have no idea what the history is on this, but I might want to send that out.
It looks like it's kind of that way on like bilaterally though, all the way down.
Yeah. So possibly this guy is older than I think. And it could be demineralization of his ribs, right? He could have some type of systemic condition going on that would take the calcium out of his bones.
Is that just the stitching from the X-ray, or does he have like more ribs than it kind of seems like he should?
On the A to P?
Yeah, definitely seems like. I don't know.
Well, let's count them. Let me get my arrow over here. So So there's the 12th rib. 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1.
No, just I don't know. It looks a little weird. Like you kind of see right around like the middle. It just kind of looks like those ribs go in a little bit more.
You mean the way they're curving around?
No, like more lateral. I don't know if it's just the angle or.
Could be the anterior part of the rib too.
Yeah.
Yeah.
You know, we don't know how heavy this person is because they've collimated out quite a bit. So they could have, you know, if they have a lung issue, they could have a barrel chest, typically like you see in emphysema. So that, you know, that might be what we're seeing there too.
Could all that radioopacity down there in the gut region be adipose tissue? Like all that cloudiness? Yeah, just all that cloudiness in general.
I think that's fecal material. I think he needs to go potty.
Gotcha.
See all that down in here too?
Do you ask your patients to take care of that if they can before they come see you for an x-ray?
You know, I kind of ask them that at the time we take the film.
Okay.
Hey, you need to go to the bathroom because that'd be a good time to do it.
Okay.
Typically, you know, they're not even thinking about that. And you don't know when they're a new patient first visit, you know, you don't really have a heads up on that kind of stuff. So I guess I look at it this way. If you really think there's something going on, but you're seeing all that gas and fecal material, then just tell them the next time you come, make sure that you try to have a bowel movement so that we can retake at least a spot shot of that area to get a clearer look at it. All right, so we kind of worked that one over a little bit with our eyes, right? Let's see what how they did their lines here. So this will be the same patient. So it looks like he was interested in that sacral tubercle. He's showing a hyperlordosis there. He's got that left ilium as an EX. But he's saying his measurement of the iliums are equal. 245, 245. I would like to make a comment on this digital line drawing. The width of those lines are way too thick. That could create 1 or 2 millimeters, couldn't it? And look, according to what his landmarks on his sacrum, he's saying the sacrum is rotated on the right, posterior on the right, so that would make it a PL. But look what he puts for his listing. So something's not right there. And again, it could be because, like we talked about before, the positioning error. So if things don't add up, you gotta be aware of that. He listed 12, but he didn't list L2. So that must be where he thinks he's getting his break, because there's the BB. That would make sense, wouldn't it? That BB is in line with that disc plane, that IVF. he's marking up here at T5, so that must be where he thought he got his break. And we were thinking it was a little lower. And he's calling PLS on 5. So whenever you see with these lines that we draw on we draw them up from the inferior end plate of the vertebrae. We go up about a quarter of an inch, and then we draw these cervical lines posteriorly. And whenever you see the lines open in the back like that, that's telling you the problem's lower. Those discs are open, either parallel or they're open in the back, and we don't start getting some posteriority until way down here on 7, and he does have a BB there. Would you agree with that listing on 7?
It looks a little different when you cover it up above it.
Yeah, if you cover up above it, I think 6 is malformed. If you look at that spinous lamina, it looks a little malformed. But the rotation certainly looks like it changes, doesn't it? Because everything is PL up until we get to 7, and then if we thought we could trust 6, everything goes PR then, doesn't it?
Would you say the wedge is on the right or left when you cover up?
Of 7?
Yeah.
I think it's still on the left.
Is it?
Yeah, you're still stacking up on that left side.
Mm-hmm.
And we thought ASR, ASRA, and that's what he's got there for Alice. So now can you see, after we've done that, if you knew some history, how much easier it would be to feel like you would know where to start working on this patient, right? Whether it's a sympathetic, parasympathetic issue.
Well, it seems like if he has a lot of fecal material just from the X-ray, you could definitely say something with, I would say like lower lumbars.
Or it just might be his time to go to the bathroom. Remember, these X-rays are, a split second in time for that patient. And so you have to always remember that once you start adjusting that spine, you're changing it. You're changing it.
So it's not abnormal to have slightly different listings. I mean, the things that are obvious in the X-ray, like the curvature of a scoliosis, but if you might have like a PRI or a PLS sometimes, you think that can happen throughout your care as opposed to when the picture was taken?
Oh, the listing changing, you mean?
Yeah.
Oh, sure. Yeah. The X-ray is important, but you don't want to put everything on it either, especially at the A to P. But the lateral, as long as that hard palate is level to the horizon, the lateral is pretty hard to misinterpret. That's pretty straightforward. Should we go to another one?
Yeah, I have the one with history unless you want to do the one on yours. All
right, go ahead. I'll stop sharing and you can throw yours up.
All right. And then you want to just tell me where to point to and everything while we're...
Okay.
Okay. So this is the history you want. So 50-year-old male patient presents with arm and neck pain that he attributes to sleeping wrong 4 years ago. Previously visited a chiropractor 8 months ago with some relief. Achy pain in the arms and neck, and massage relieved the symptoms, and typing made it worse. Extended computer use and opening bottles and cans are painful, and he has trouble sleeping. First adjust. Oh, well, let's not look at that. You want to see this first before we go into what they did?
Yeah.
Okay.
Does it say which arm and which side of the neck?
No. In the
That'd be
arms
kinda-
and neck. It says arms. So
Arms, both?
yeah.
Okay. Does it say which side of the neck?
No, it doesn't.
And he doesn't have any lower back or thoracic complaints that they know?
Not on this. No, not on this case.
Okay. All right, go ahead and put up what you got.
All right. So this is the lateral. Where
Yeah.
would you like me to start going?
Why don't you start on the sacrum and we'll work our way up?
All right.
Does it say how long he's had the problem?
I think 4 years.
Okay. Is this a male? Yeah, male patient. Okay.
Yes.
How old is he again?
50.
50. Yep, 50-year-old now.
Yeah, see, he's full of gas too. Gas and fecal material there.
Mm-hmm. He's ready to go.
Can you zoom in on that sacrum a little bit more?
This is as much as I can go right now.
Can you get rid of that, whatever that is in the middle? There you go.
There.
Thank you.
Okay, found it. Figured it out.
All right, go ahead and make that bigger again, if you can.
Okay. Let me just make sure real quick. Oh, this is Dr. O'Hara. To let in.
Oh, he's on? Okay. Well, we'll stop. We'll let Dr. O'Hara take over.
All right.
Hey, Dr. O'Hara.
It might take him a sec to get everything figured out.
Hey, Doc.
You gotta unmute your mic.
There he is. We can see you, Dr. O'Hara. We just can't hear you. So
Yeah, you gotta
to the
unmute.
bottom left, at the bottom where you see the red hang-up button, go all the way to the other side, on the bottom left. You press that.
I get it.
Yeah.
Yes.
I get that.
Hey, Dr.
I
O'Hara.
get it now. Hello.
Yes, we can.
Thanks for joining us.
I just wasn't sure I was going to make it. I wanted to do it on phone, and it wouldn't do it. And I had another computer sitting there, and I couldn't get the sound to go, so I had to go run grab another computer from upstairs. So sorry I didn't get here in time. So.
Oh, you're fine. You're fine. You had a busy day, I'm sure, today.
Oh, Dr. Scott, there you are in the corner. There you are up in the corner. There we go. Well, what's the topic today? What are we meeting about? Hey, it's 95 degrees up here. What is it down there with you guys right now?
About the same.
Is it about that? Is it?
We just said-
Yeah. That's our normal.
That's your normal. Okay. Well, this is a bit abnormal for us, but we're suffering through it. So
It grows the corn,
I was
right?
thinking about you guys down there. So corn looked pretty good. Did you watch the Field of Dreams game? Did you see it?
I saw part of it.
In Dyersville? Yeah.
How far is that
I
from where
think
you're
they
at?
brought in fake corn. Oh, it's
It
all
looked pretty good, didn't it?
It's all good around here. Yeah, it's all good. But But I think that some of that was fake corn they brought in. Cause I don't think any of it looks quite that good. So.
It looked pretty good. So what we were doing is we've been going over some x-rays that I had on file. We didn't have any histories with them, but we were just kind of talking about interpreting the x-ray, making sure we use good x-ray positioning. How much can we trust the x-ray based on that? And then trying to come up with some listings, some tentative listings. There were some BBs on these x-rays, and so the BBs, I think most of them were where the doctor thought they were getting a break. So we were talking about, that disc plane line and how accurate are we with where we're reading that scope reading. So if you want to take over with that or whatever, or whatever's on your mind, go ahead.
I never BB'd them for years and years, and then I started BB'ing them, and what really surprised me is in the cervicals, I was pretty close to what I had counted. I was usually pretty close to that. I was amazed how many lumbars I was off. When I put a BB on a lumbar, they're so big you don't think that you could be on the next one, But
a lot of it depends on that curve too.
I was so surprised that there was lumbar ones. It makes it tougher with that curve, yeah. Tougher to miss a thoracic. But the lumbars, until I BB'd them, I realized, holy cow, my count wasn't right on, more than I want to admit. So I must have been hacking away on a lot of people.
So you'd say putting those BBs on the films actually makes you a better chiropractor, right?
By far. Rick Albert gave me, I didn't put the BBs on. Well, I had pellets anyway, but a lot of times they don't. It just goes right through them. You don't actually get a good picture of the. Sometimes it blows right through it. Depending on where you're, like a side view, especially a lateral, low back. You're not going to see them. Rick Albert come up with these great big shot balls. I think he shoots deer with out of a musket or something. And he said, tape these on there. You won't miss them. It's like a big lead ball is what it is. And that helped a lot to get something thicker. And now I use the tip that comes on the single probe instrument. When you buy that single probe instrument that we use, you guys know which one that is. It comes with a real sharp tip that unscrews, and I got that taped up, and then I taped that to them because it actually is like a pointer. It points right through them, and it's thicker in a way that you get to see it no matter, even if it's a thicker person you're X-raying. So I've been using that. That seems to work pretty good. You don't need that clear up high in the cervicals, but down low sometimes you need something a little more lead in there to block it off. So So I've been doing that. Film is certainly not my specialty. In fact, I take a film on everybody, but I see the other people's films, and I'm not proud of mine. I see how the digital films are doing, and even Michael's films up at the clinic. He shows me his films, and I say, I don't want to show you mine because mine looks so bad,
So you have an analog net still, right?
Yeah, I'm analog, just like me. I'm analog. I'm not digital, as witnessed by how long it took me to sign on to this thing.
Can I ask you a question about the X-ray machine at Mount Horeb? So your son Michael, he works there. Yeah. So did they have to make changes on MD, AD as far as do they take their ADP from 84 inches or do they up tighter like 40 or 60?
I think they're up tighter now, and they're part of it is the up till now the power of the machine, the power that machine had, and when we put in the digital, they recommended a lot higher powered machine like Josh has. Josh has a hospital machine. You know, Josh, he does. And they recommended that, but we couldn't get that power. We couldn't get that power to it because when Gonstead built that place, that's solid. There's between the floor and that X-ray room, it's solid cement for I don't know how many inches. It would have taken a lot to get the power, that higher power there. But that's just been getting fixed now. So we've got a guy that said he could get that power over there, and he's either working on it now or he's going to do so real soon. And at that time, we're going to put a little higher power machine in, because Josh says in order to shoot from 72 or shoot from, from the further distance, you got to have more oomph in that machine to do that.
So do you know what the technology is if you're going to shoot it closer for that ADMD measurement and rule to work? Is there a cephalic or caudal tube tilt?
Now, I don't think they do that. I've heard people talk about that. I told them that my solution to that. Now, people would say this, you probably shouldn't do this. I would back my tube up just like I would take the full spine A to P. I've suggested, why don't we back the tube up just like you take a full spine A to P, and the plates are only 14 by 17, or they're only halvesies, and take that, keep the tube right where you would normally take an A to P, and then put that halvesy down there and use a lead blocker to block off the top half. So you wouldn't get the radiation to the patient, but the radiation would have the same angle. And then I think that would make the correct. You think so? Have you thought about that at all?
Well, now that you mentioned that would be a way of getting around it, wouldn't it?
That was my thought for a while, was to try that. But I think in that instance, right now Michael says he's getting terrific films, and a part of that is that tube is so close. He's not having trouble penetrating anybody, and that makes a heck of a difference. You bring that tube up like that.
Yeah.
And I found after we talked that through and we thought about that for a while, I started bringing up my low backs. You get to somebody that's 290 or 320, and I was guessing what I was seeing on that film, So I got to where I would bring that, even on the A to P, I'd shoot a 14 by 17 and bring it right up close. You can get so much better penetration, So I don't know if I'll ever go digital. I don't know if I'm gonna live long enough to do that. So I may never go digital.
That's why you're such a great palpator, right?
I don't know. No. Yeah, because I don't look at the film. No, I do rely more on my palpation than the film. Yes, I do.
Did you guys catch that?
And for years I did. What's that now?
I was just asking them, did they catch that you said that? Everybody wants to adjust off the X-ray.
This is a full and complete confession here today. I did the same thing with the scope for years and years. I always ran the scope, but looking back on it now, I was running the scope. In other words, my scope was going, okay, I scoped them, and because I'd already determined where I was going to adjust and had static palpation, motion palpation, and I'd run that, and if it looked like there's a break there, I wouldn't go over it 18 times, But others have pointed out the error of my ways, and I do spend a lot more time scoping now than I used to. But I feel so sorry for those first patients that first 10 years. They got a little different, I guess. So.
Oh, no.
But, yeah. So, but as far as the digital X-ray up there, they're going to make some, like I say, they're going to make some changes and put in heavier duty machine now that they can get the electricity through it. So I'm looking forward to doing the full spine like Josh does. You know, Josh gets his films are terrific. His are really terrific. So, and that's
he's
where
shooting
we
at
need to move
40.
on, you know.
He's shooting
We
at
got
40.
that. We got that. No, he's shooting it like it ought to be shot.
Okay, just more power.
Yeah, Josh is. He's shooting the poop. Yeah. He's got a hospital. He's got a machine that came out of a hospital, and it's got a lot more power than the ones that we normally would use in a chiropractic clinic, and that's made a big difference. And so, that, like I said, we're going to do that. We're going to try to do that up there too. You know, when we first got the machine, it was donated. It was wonderful. Terry donated that. The guy that comes to and he sets up his table at all of our seminars, and he donated that machine to us. And if we had any trouble with it, it was never a problem. Terry just take care of everything. It was made a no-brainer. But he put in the best he could with the power we had. And like I said, at some point that will change. But what kind of questions do people wonder about? We had a heck of a go around there in the basement of Mount Orb here the last time. That was fun. We had I don't know how we got on different topics, but we got on different topics there and had all kinds of things to talk about. So I don't know if they're interested in doing case management stuff or what they'd like.
Yeah, honestly, like
I always think I know what's important for them to know. Go ahead, Marcos. What's that?
I was just saying that conversation that we were having, kind of just about the science part of the clinician that you also talk about on the 1505 podcast, and also just all these little different things that we can do to make sure that we're figuring out what the subluxation is and the correct one. I mean, that was huge for us that we're able to sit at that circle and talk about that. We wanted to kind of bring that kind of to everyone that wasn't able to be there and just kind of discuss some of that case management stuff that you were discussing. And we started with the disc, the different...
I don't know what kind of cases...
Like how you started with the different... the two different parts of the nucleus. That's kind of how our conversation started, and then it just went into
that's right.
Yeah. So I mean, if you want to just kind of discuss that and how different that palpates, how different that is for each patient, how that's different for what table to use. If you want to kind of just go with that, that'd be amazing.
I think it just gives us it answers the question, why is there such a wide variety of what we see? And as young students and young doctors, you're going to find out, you're going to set up to adjust on somebody, and you've got a PRS written on your card, and you're going to set up and you adjust a PRS, and you adjust that PRS just as well as Gonstead would. Just to get a whooping soccer on it. That's what he called them, and you adjust it just like Gonstead did, and at that point you're like, hey, I got this down. This can be okay, This can be easy. And then the next patient comes in and you do all the analysis. You wind up with the same listing, and it don't go at all. It's like, in fact, you can tell it isn't even close to going. And it's like, okay, wait a second. I went through all those steps, and I come up with the same 3-letter listing. And you have to step back and look at it. There's how many varieties of PRSs. And that's what I think separated Dr. Gonstead from all the rest of us in the crowd, because he was just that much more specific. Just that much more specific. And I don't know how he thought about it from a mechanical standpoint. He just palpate it and tell what it is. I learned a lot about thinking about it different from one of his last videos. When he was in Portland, the seminar that's in Portland, they had a lady sitting there, and he was doing a second cervical on her. He was analyzing a second cervical, and he was telling at that time, he said, now see here, fellas, he said the pressure's on this left side. There was a C2, and I can't remember what listing he gave it. But he said, the pressure is on the second side over here, see, fellas. But you can't set that from left to right like we would think normally through the plane line of the disc, because the laterality is to the right. And it's like, huh? What's he talking about? And this is a video, and that he talks about this for a while. It's a lady in a striped shirt, and you can see her part-time, and you can see her some of the time not, because Herb happened to be sitting right up close, and Herb would move a little bit, and he'd get right for the camera. So we blaming Herb for not having a full video on this thing. But he would say, no, you have to set that. You don't set this across to there because you'll make the laterality on the right side worse. And these guys had all followed him for 100 seminars, and they're all like, what is he talking about? You know, you could tell he's telling them something that he thought they knew and they didn't know it. And Rod Campbell, who we have to thank because Rod would always ask the right questions. Rod came up and Dr. Gonstead said, see here, you're going to set it on the left side because the pressure's on the left side, but you can't set it across like that because it's already lateral. It's already lateral to that left side. He said you have to set that around this way. And he kind of showed the angle that he would do that. He kind of showed the angle that he would do that, pull that around that way. But and Rod said, well, I would have pushed it that way. And Dr. Gonstead said, yeah, and you'd been wrong. So these are guys that had done hundreds of seminars with him, and they were still learning stuff in his last year. He was still teaching them stuff. And to me, that one right there rang a bell, because it's like, wait a second, you mean I taught this stuff for a long time. And I always said that the angle that you want to go through is exactly the angle where the protrusion is, if it's through the left side. That's the direction you should go. But he's taken into account more than just that. He's taken into account the entire picture of what it's doing.
Say, Denny, do you think in that case it had to do with inferiority?
And that's where we need to stay. He didn't mention that.
Okay.
I've got that video. Usually when I bring that to a seminar, I make copies for everybody, and it's not a problem. I'll copy that for everybody on this meeting tonight. You can all look at it.
That'd be great.
And maybe you'd get something different. Yeah, maybe you'd get something different than I did out of it. But it made sense to me because so many times, like you were saying, you're looking at films, and you BB that film where I always BB it where I find the pressure. And you BB that film where that pressure is. Well, sometimes let's say that BB's on the left side. Sometimes that BB's on the left side and that spine's sitting over here, and the BB's sitting on the left side of that, the spine going this way, and the BB's over here. Sometimes the BB's on this side and the spine's going this way. Well, they're two different setups. They're two different corrections. So if you can have other components. At first I would call it side slip, and I always say look to see what side the side slip is on, and you have to adjust accordingly. If it's a PL and you're on the left-hand side and that thing's bent this way, if you set that from left to right, you're going to help correct that. But if that's a PL that's on that side and it's bent this way, if you push that way, first off, you're not going to move it anyway. In fact, thank goodness you're not, because you probably make it worse. But that's the one. If the trouble's right here and it's bent this way, that's the one where you bend them further. If you set up on them, you would bend them over further. The other one is one where you keep them up straight. And that's where we have to look at ourselves and know ourselves in our setup, because there's a certain natural positioning that we learn when we're practicing, and some maybe it depends on the type of cervical chair you're using, or other issues. It depends on different body types and different lengths of fingers and all kinds of things. So if your normal setup, and Dr. Scott can attest to this, if you watch Dr. Troxel bent them further when he adjusted them than Dr. Herb did. When you watch Herb adjusted more from the straight up and down position. Dr. Troxel had more in a bent position. And if your natural is to do it in a bent position, then the one that's bent this way, you're gonna have trouble with, because you're bending it further that way. The one that's bent this way, they're gonna love you. They think you're the greatest doctor in the world for that one, because that's your natural. That just comes easy to you. And it's when it's the other one that you have to put in your mind, I got to keep this straight. Or if you normally adjust straight up and down and you need to bend it, you have to, I write a note to myself, bend this. And so I get a better adjustment when I bend it. And the next time I get a better adjustment, and about the third time I kind of forget, because they're doing a lot better. It's like, oh gosh, it's 90% gone. So do I think of that again? No. I'd go ahead and adjust it, which I kind of keep it straight up and down. When they come back the next time, they say, that wasn't as good. So they let you know that right away. And so like, I'll write down their card, bend it. And I have cards that I have on patients where after a couple visits, I don't pay attention to bend it anymore. And I realize I need to. So I'll write bend it on there, like 3 times the size of everything else written on there, and then put a red circle around it so that I can see it from my cervical chair. My exam chair is right next to my table, my desk, where I have all the paperwork. But then my cervical chair is the next step over. And so I write it big enough that I can see it halfway across the room. I write bend this, because I'll forget, and that's not my natural, see? And all of you, every one of you, will have a natural. You'll have something that's kind of home base, that you're going to get all kinds of them set real nice and easy, and that patient's going to get better and love it. And then you're going to have some tough ones. And those tough ones are the ones that go away from your home base. There's lots to think about. But if you just stop and think through each one, once you figure it out, the rest is easy, because you only have to figure it out once. It's easy.
Doc, is there a certain thing that you palpate?
Is that what we talked about?
Yes, yeah. So is there a certain thing that you're feeling when you're...
I'm sorry, what then?
Is there a certain thing you're feeling about right before you're about to thrust that's telling you you're going in the right direction, as opposed to, I need to adjust the way I'm doing the setup?
Yes. For one thing, you're going to set up on that, and you're going to actually put some pressure against it. Let's go back to that example. Let's say it's trouble's right here of this finger. I don't know how well you can see. And if you got this one here. And I set up on that one and push that across this way. Well, does it go easy this way, or does it go easy this way? If it's like this. I'll exaggerate that so you can see my hands going that way. If we're looking at the spine, and the spine is bent that way. It's bent that way. Does it move easier this way or easier this way? Mm-hmm. Somebody answer that.
I would think easier away from the side of pressure in this case.
Yes. It moves easier. It'll move easier in the direction it already is. It has a difficult time coming back this way. So if you set up on that one and you put a push, and you push that left to right like this, and it just moves over there nice and easy. It's not an adjustment that you need to do. Okay. But you take the same contact and you pull it over this way, and that's where it's restricted. And so you can tell by your adjusting finger that when you bring that over across on there, that doesn't want to go that way. That's figure out what it doesn't do and make it do that again. That's a model. That makes sense?
Yes, that does.
It goes for every angle that we use. Okay. And that works for every angle that we use. We're just talking about left to right laterality, side slip. Dave Rowe has Dr. David Rowe in New York, he has a good word for it. He calls it translation. It translates this way, or it translates this way. So he calls it translation. I think that's a much more accurate word than any I've ever used. So you're looking to see what direction it doesn't translate, and we want to make it translate that way. You can make it do that. So, but that's just the simplest thinking left and right. We get that same thing from front to back. There's the exact same thing from front to back. One of the first things you want to check on anything, once you find where you're suspecting the subluxation, is it restricted in fixation, in flexion, or is it restricted in extension? Because if we're pushing it the direction it already moves, we're going to fail every time. We're just going to fail. It's just not going to work. If you get it to move, it's going to move the wrong way. So you can tell that real easy, whether it's in the cervicals or lumbars or whatever. You just barely tuck them forward and then tuck them back. When you compare those two, you don't compare it to anybody else, but to that particular segment you're feeling. Is that segment more restricted in flexion or more restricted in extension? And you have to take that into account no matter what you're listing in, whether that's a PRS or whether that's a PRS. It doesn't matter. Did that do something? Did we phase out there, did we?
Nope, you're good. You're good.
Mine had a hiccup there. Okay.
So how do you?
So
there's
PRS, but there's PRS where you stabilize and pull it over this way. There's a PRS where you stabilize and you push it that way. There's a PRS where you lift the chin up further. There's a PRS where you bring them back, where you make sure you adjust inflection. There's all kinds of variations. And it's just a matter of setting up on it and feeling which way it's restricted. Then the rest is theory. Everything else after that is theory. So. Is that clear as mud?
Hey, Doc. It's Steven Salinger.
Where are we at? Yeah.
I think their camera might have froze. They were having some internet problems. He'll pop back up.
Oh, was my camera froze?
No, Marcos was.
Okay.
Yeah, they'll be back in a minute.
Oh, okay.
There he is.
Oh, there he is. He just joined again. Hey, where'd you go?
Sorry, I lost Wi-Fi for a second. You said your Wi-Fi was my Wi-Fi.
Well, mine's pretty bad here. I tried to get it on the cell phone. That connects through Verizon. That's a real good connection for us here. But I'm on HughesNet here, and with Zoom with my grandkids in Chicago, and it interrupts and it goes slow and all this. And I called HughesNet, and the gal said, "Well, if you don't use the video, it works a lot better. Just turn the video off, and it works a lot faster." I call them on the phone and do that. But we live out in the sticks here, and you can't get a good internet connection. Actually, the whole state is in sticks, but we're even out further. So no. Anyway,
it's been working well so far.
Any other questions about something, or any other direction you want to go?
Yeah, I was going to ask about how are you palpating for flexion? We have a very good understanding, I feel like, how to get the extension fixation, but how are you palpating and figuring out if it's stuck in flexion?
Always take, always start from neutral, and always do all your angles twice, and then come back to neutral. Because you never want to palpate flexion and extension. Flexion and extension. You want to do that because you're doing both movements. So if you're going to palpate that, you want to palpate inflection back to neutral, inflection back to neutral. And then you compare that extension back to neutral and extension back to neutral. That, by doing it twice and stopping at the neutral, it gives you the comparison because it might have fixation in flexion and extension. It might have lost range of motion at this plane, in this plane. But what part of it is where the fixation is. And it's always at the start. So if you start at neutral, and you go as far as they can go, it'll tell you nothing. Because it overcomes, once you get past a certain point, it overcomes a restriction, especially if it's a small restriction. So you want to start just at neutral. You want to start at neutral, and you want to flex twice, stop at neutral each time, and then extend. And each time stop at neutral. And you compare those two, not to anybody else or what you think it ought to be, but it makes it so obvious at that point. It really makes it obvious.
We had a question from
not 100% of the time. Sometimes they're difficult. Sometimes the fixation isn't necessarily that way. So does that make sense?
Yes, thank you. We had a question from the chat that
Can you
asked, oops, sorry, what? So
go ahead.
In our group chat, in the chat right here, it says, in the lumbars, do you contact the same part of the spinous for flexion versus extension, or do you shift when doing flexion?
I never contact the spinous. I don't touch the spinous. I never touch that. I'll put my fingers where I feel, where I found the pressure. So wherever the nerve pressure is, in the scope, sometimes they're way wide, which you find the reading over here. Sometimes it's close to the spinous. So wherever I find where that's at, I mark that, and then that's where my fingers go. So I don't touch the spinus. Oh, is that bad? Is that bad? You guys aren't going to teach me I'm not going to learn the handshake, am I?
We've only kind of been taught one way to in school, and they always reference the spinous when we're teaching palpation in school. So you're going for where your break is, or where you're feeling the most restriction in where the wedge is, and then that's where you're palpating from?
Yeah. It'd be at the level of the break, but also the width of the break. See, so you can always tell it is track sensitive, and the scope is track sensitive. You put them clear and close together. If the readings clear out towards the transverse, you won't get that reading. See, so when you're scoping, say a second thoracic, which is pretty wide, let's say you're scoping a second thoracic, you might find that reading. Oh gosh, quite a ways away from the spinous. That's where I'm going to palpate. That's where I'm going to put my fingers there to palpate that spot. Inflection and extension and all the other directions we're going to go. That's where I have my fingers. Now,
are you contacting like this, kind of? Then are you contacting like this, comparing side to side, like on the spine? Or are you just having one or two fingers in that area?
On each side, you mean? Contact. I would stay on whatever side I found the issue. So I wouldn't like sometimes I'll go up the cervical spine, both sides. But for the most part, once I'm motioning it, I want to motion it where I found that break, at the level of the break and at the width of the break. I'll mark it and put a little dot on it. That's where I'm going to put my fingers. And when you feel that spot. When you find that spot and you feel that spot, that's where the patient will, so many times will say, how can you tell that? They'll know you found it. Because you're going up, you're going down, you're going back and forth. I always feel the good side first. Always. They come in, they got pain down the right arm. I'm feeling around the left side. Look for the good ones first. Then the bad one looks obvious. So you're feeling around left and right and wherever you're at, and you come to that spot, I mark it, and then I'll feel over again, and I'll go past it. I'll go up past it, come back down past it. You have to go past it, or you don't know where it's at. See, if you stop on it, the only time I stop on it was when I want them to know that I got my finger on it, and they'll know right away. They'll say, most times, many times, they'll say, "You're the first doctor to walk around behind me." You know, they might have been to 10 medical doctors and 10 chiropractors. They do their examination sitting on the chair in front of them. You know, ask them questions and lay on the bench and lift their leg and do a bunch of other stuff. But nobody ever walked around and touched their spine. Put their hands on their spine. That's real odd for them. You know, that's why a lot of times the gals will come in. The guys will come in to the same thing. I gotta take my shirt off? Yeah. You know, and then I can hear Julie putting them in the feeder room, and I hear their question. They'll say, "I can take my shirt off." You know, the guy. You know, well, yeah, you have to take your shirt off. Why have to do it every time? It's like, yeah, we're going to examine your spine. They've never had that done before. They've never had an exam. And nobody walked around behind them and actually put their fingers on it. And those are the ones so many times. I had a guy just the other day. I find where it's at, and then I take my tape, I put my BB or pellet or whatever I'm doing, I put it on. I said, put a piece of tape on you. I tape the marker to you. We're going to go take an x-ray and that marker show up on that film. And the guy got out of the chair and turned around and he said, "How did you know where it was?" He said, "I could tell when you stopped on that spot." And it's really what it comes down to is it feels different to the patient. It feels different to us. It's the one that feels different. And once you find that, the rest is so much easier. If you don't find that, the ones that don't find that, that's where you get humbled. Then you're hunting. Every time they come in, you're hunting for it. So it's best to find it the first time. Take the time that you need and find it the first time.
So you like to palpate?
I palpate too, right from the pressure.
So you like to palpate the good side?
Palpate the what now? Yeah. I was palpating. And you know, what's the good side? You really can't tell from the history, but kind of. You know what I mean? Somebody comes in, they got right leg pain. I start by feeling the left side. And I'll feel the left side. And I'll go over, feel the right side. And I go back to the left and go back to the right. You go back and forth and switch hands. And you go back and forth again. Along about the third time, it comes pretty clear. At about that time.
So
I just spend more time with that than anything else I do.
Are you not too worried about the
what?
rotation and the lateral flex, like the exact mechanism listing of the segment when you're palpating? So how do you find whether it is the PRI, PRS, or do you not really worry about that? You worry more about where that nerve pressure is and then removing it?
No. When you find where the nerve pressure is, the first thing I want to do is know if it's flexion or extension, if that's an issue. The next thing, you can check rotation, but you hold that spot, and you add those parts of the listing. So let's say you found on the right hand side of first thoracic, and it's restricted in flexion. So I'll take that. Keeping my fingers there, I'll take and I'll turn them a little bit that way and move them through flexion. Then I'll turn them the other way and move them through flexion. There you got your rotations. You can tell, it makes it real obvious. You're loading it up at the two different directions. And it'll tell you which combination of that's there. So the rotation's real easy. We all think of that pretty much the same. The one that's different, I hope I can say this into the camera. The one that's different, that I do different, that I hear different, is the wedge part of the listing. If that same one is superior on the right hand side, I want to look and see if it's got an S on it, if it's superior on the right hand side, and I'll bend it down that way, like we all do, right? And then I'll bend it. First I'll bend it to close it down, then I'll bend it to lift it up. And that's where I hear too many times when people are doing motion palpation, they bend it down to the right side, then they move their fingers over to the left side and bend it down that way. And so the left side means nothing to me once I find the subluxation on the right hand side. So what we're looking for with that lateral bend is lateral bend, 1, and 2, lateral lift. So what you're going to check for, does it close down on that side or does it lift up on that side? Some of them we torque down, some of them we lift up. And you do it all from that spot that you found the issue. So you find that particular spot, make sure you see if it lifts up. You don't go to the other side and see if it closes down. That just muddies the water. You're going to adjust through that spot. That's where the subluxation is. Now, how are we going to do it? Are we going to torque it down? Or are we going to lift it up? Are we going to add flexion? Are we going to add extension? And the rotation part comes, like I said, rotation is pretty easy. So you drive all the letters of your listing with your fingers on where the subluxation is. Is that different?
Yeah, that is different than what we've kind of just heard, because I think we try and do just a very foundational, fundamental way of doing things, and then being able to build off that, because to feel the way you're describing, you have to have some skills to feel that, I feel like. So we definitely start with, no?
I disagree. Day one. You can do it day one. It's just a matter of thinking it through from a different perspective. I don't think there's anything wrong with touching the spinuses and getting the entire listing from the spinous. I don't think there's anything wrong with that. That's why I learned it too. So that's not wrong. I would never say that's wrong. But I like to be on the spot where I'm in contact when I adjust. See? And that's the spot I'm in contact. Whether it's a spinous listing or transverse listing, whether we're lifting it up or torquing it down, that's my contact. That's what I'm going to be. Okay. So now I'll give you a pearl. This one you got to write down. This one you should write down, because this came up with the January seminar, and so many times we'll get things moving around, and I found this. People send their they take and they find the subluxation, and I think they truly find where the subluxation is. Then they go to the film and they list that vertebrae. That's wrong. That's wrong. Don't list that vertebrae. List that spot. The spot that you found, if it's on the right-hand side, you need to list that spot. And there are certain listings that are right-sided troubles. PR, PRS, PLI-T, and PL-T. Those are all four right-sided problems. But if you find that spot on that right-hand side where the subluxation is, they got a headache up the side, they got down the right arm, and you come back and say, you look at the film and you do all your analysis, and you come back with a listing of PR-T. See, that's a subluxation on the left-hand side. A PR-T, you would contact the left side. See? So you can list that. You don't list the x-ray. You don't list that vertebrae. List the spot that you found. And that spot you found can have certain listings that are adjusted through that side. Don't let the film looking at the film, don't let it change the side that you're on, because the subluxation's over there. But see, the listing, if you look at that listing, you might say, oh, geez, is that PR, is that PL? And people wind up adjusting on the other side, because that's what the listing is. But the other four listings are for problem on the left-hand side.
So when you have opposing things like that, where the subluxation is on the right side, but you're getting on the film, it's saying something's on the left side. The problem, it's saying it's a PLS, say. Does that make you think that what does that make you think? Just what goes through your head?
It makes me think it's not PLS. It's PLS on the X-ray, but what it can be, it can be PL-T. See, because the trouble's on the right-hand side. If you go to the film and that film is open on that left side, you think, oh, we got a wedge on that side. Well, maybe not. Maybe not. You might be inferior on the right. See, you don't have one that you have to torque down over here on this side. You have one that you have to lift up. You can't make my finger do that. You have one on that side you have to lift up. So in that instance there, the film never lies. People say that what do you do if your palpation says something different than your X-ray, and it never does. It's always accurate. It's always accurate. There's never a decision to make between the two. No.
So when
it's
you're,
just
list
the spot that you found.
So that scoping is
I'm going to get a little closer. Hold on. Say again now?
So that scoping that you're doing when you're going down the spine and you see it, say the heat's over to the right and it's all the way like 20 points over the right, and then but there's a break to the left that makes it to maybe 10 points on the right side of the scope reading. Is that telling you that the pressure is still on the right, or is it on the left where the break is?
It's on the left. Yeah, it's on the left. Yeah. There's a difference between the reading and the break.
Mm-hmm.
There's a difference. There's all kinds of things that change the reading. But there's only one thing changing break, and that's chiropractic. So the break is a very the break is a temperature increase over a very small area. The break is a temperature increase that's in the dermis of the skin. That's where the subluxation shows, is in the dermis of the skin, very superficial. Now, we can have underlying tissue that can be all swollen and red hot, and all kinds of things produce heat, so there can be a great big heat swing that way with a break, or like what you're describing would be like, say, we talked about the other day about a chronic one. Yeah, that chronic subluxation, and it's colder on the subluxated side. That'll do that just like that, but the break will still be to the side that the subluxation's on. That doesn't change. It's just real easy. It's like driving on the highway and you see a car accident, you can't help but look. When you see an instrument reading that goes clear over one side, it's like, wow, look at that, But the actual break is a very small. It's over a very small area. It's the neural inflammation that's put there from the windup in the nervous system. That's what's there. There's all kinds of other things that produce heat. That hot nerve, that disc is all swollen. There's all kinds of things, but none of those are things we should adjust. The only time you should adjust is when the break is there, the break from the subluxation, and the subluxation. The signal that you get from that is a chronic signal. It's your body puts it there. It puts that there from the windup, the chemical windup in the core. Feeds back down, antidromic, down into the dermis, and it affects the vascular bed. It causes the arterial side to swell and the venous side to leak. And so you have both heat and you have extra fluid in that area. And that's what that scope picks up over a real small area. Real small area. It's the little breaks that really fix patients. You see the great big thing going over the side. Think, oh, that's got to be a good one. Not always. It's that you find that little and you fix that, and you really get something. You get something.
So yeah, we asked this question too.
Have you guys?
I'm sorry. What was that?
Well, go ahead. I didn't know if that was something you guys had already discussed or had. I think Dr. Dave did it at the last seminar. Dr. Dave Gary did it at the last seminar. He talked about neurogenic edema and the subluxation.
So if you're getting a scope reading at a certain area, and we discussed this a little bit right before you came, say you have a scope break at T6, but then you look on the film and then you see that that's in the middle of some sort of stacking, and T8 might be the bottom of that stacking. do you ever go off of your break and onto the biomechanical side, or do you normally focus more on where that exact break is?
I wouldn't go away from that break. Well, what I would do in that instance, when the film shows you something like that, I'd go back and examine to make sure that I didn't miss something there. I'd look for that and see if there's it could be a very small reading, or it could be palpating wise. Maybe it wasn't the most obvious one. They might be getting their pain from the 6 because it's all swollen and irritated, but the problem that's really going to fix it might be the 8. In that instance. So you want to go back and look. You want to go back and look at that when you see that. So there's all kinds of things that happen. But just what you're saying, you saw it on the film, so you're going to adapt or do something to correct that. You're going to be aware of that. So no, you're doing the right thing by looking at that and making a decision. But I wouldn't go down there and do that if there's no break there. Not from a break. Keep it in mind for later. Yeah.
Paul, did you have a question? I know you were trying to. He's driving, so I know that he.
Oh.
Hey, Dr. Denny, how are you?
Hanging in.
Sorry, not sure if you can hear me. I know there's a little bit of a delay. I'm driving, so. My question goes back to your palpation. I know we talked about this a little bit at the seminar, and you crack me up because you just say stuff we've straight up never heard before, and you act like it's like exactly how we're taught. You crack me up every time. So when you are combining your motion on the palpation, can you explain one more time how you're doing your extension? Say you found the restrictions in extension. So now you're going to combine the rotation, and you're also going to check for lateral bending. Can you just I don't know if you need to mime it out for us, but can you show me how you're combining that motion in order to find exactly where that subluxation sits?
I think you already know where the subluxation is, but that's a great question about how you can combine all that. I would go with, if you find a difference in flexion and extension, I would put them, let's say there's more restriction in extension, then I would have them in extension. I would put them somewhat in extension when I check the rotation. I check the rotation right and left. Or you can do it the other way. You can turn the rotation and then bring them back in extension. Turn the rotation and bring them back in extension. So you just combine those components. You might find that here's what you do. Let's say you do this. You bring them this way and you bring them in extension, and then you turn them that way and you bring them in extension. And then you bring them back this way and you bring them in extension, and you turn them that way and you bring them in extension. Somebody stop me somewhere on it. You turn them that way and you bring them in extension. When it gets to where you go back and forth, you don't see any difference. There's not any difference. See? So what you're looking for generally is pretty obvious. And if it's an important component, it will be obvious. And you'll find it at the very beginning. At the very beginning of the range of motion. And if you just do the math on range of motion, if something bends 100 degrees, just throw that out. If something bends 100 degrees, which it doesn't, and it's restricted 10 degrees, you're going to bend them that way, and it's going to have 90% of its movement. You bend them the other way, it's got 100% of its movement. That's a hard comparison to make. But if you check it at the very beginning of the motion, the very beginning of the motion is where the restriction lies. So when we just bring them, let's say we just bring them 20 degrees, and then bring them 20 degrees the other way. That's a 50% difference. That's a real easy one to see. So many times you want to make sure that you just palpate right at the very beginning. You want to do just the beginning. So that brings it out all the time. I see people doing, palpation where they're doing a whole range. And I'm thinking, I could never figure that out. If there's something that's lost, 10% of its range, it's hard to tell when you take it to 100%. So start with that. But all of those different positions, I would try to load it up at an angle that felt like it's restricted. And if extension was a portion of that, I'd try to do most of it through extension. See? Or if rotation is, if there's hardly any rotation to the left, then rotate them left and check the extension. Rotate them left and check the flexion. See? So you want to load them up. And once you see part of it that's obvious to you, then load it up at that angle. It might be that that's the only angle that's restricted. You very well could do it. Did that answer that? I'm not sure if it...
Yeah, Doc, that was a really good explanation. I think what you just touched on was a key component that we often pass by, especially in school, is we stress the joint too much. And I know Brianna caught me one time because I was finding restriction at the end range of the joint, and that was more global restriction rather than segmental restriction. And the segment I was on actually was restricted on the other side at the beginning of the motion. So that was just a good check for me, and what you were just explaining is exactly that. So I thought that was a really good point. And then question for you, so you're saying to check so you're going to rotate, you're going to check flexion, check extension once you find it the most restricted. And then can you touch on how you incorporate the lateral bending, or are you waiting more until you're getting ready for your setup to find exactly where the lateral bending restriction might be?
No, you can palpate that. You can palpate that lateral bend, but you want to make sure that you check just that side. So all too often, what will happen, Doc, is I'll watch some people, they're checking lateral flexion, and then they go the other way. Well, what side's the trouble on? Well, if it's on the right-hand side, you want to check lateral flexion on the right-hand side, and then keeping the fingers in the same spot, see if it lifts up. Bend it this way to see if it lifts up. When you bend that way, you don't put your hand over here. You keep it right where the trouble is. So you're checking to see if that segment closes down or if that segment lifts up. Because they're two very different adjustments. You know, whether you're going to torque something down or whether you're going to lift something up, they're two very different adjustments. And the one that we don't think about, is the lift up one.
I think on top of that, you were mentioning that you're not going to combine the rotation with the lateral bending, right? You're going to check that more so from neutral, where the head is not rotated.
I think you can actually put them all together, but I think I separate them. I think I do, but I don't see anything wrong if you can combine them all at once. I don't see anything wrong with that at all. You know, in the end, we're going to anyway. You know, and when we go to adjust it, we should combine them all. So, you know, to do the individual components, you know, you might find one that's real obvious, and sometimes the other ones aren't. You know, people say rotation is the least important of all of them. I tell you what, you get a problem that needs rotation, you ain't gonna fix it unless you rotate it. So it's just as important as all the others. Maybe not as common as the posterior inferior ones we see. You know, we see posterior inferior ones. You know, but so there was something else with that came with that question. I was going to say. Okay. Yes. To follow a little bit with what you're asking there. When you're on that side and you're checking to see if it closes down or whether it lifts up, that's precisely why the film will lie to you. Because sometimes if it's inferior on this side, let's say we find that problem and it's inferior on that side, we have to lift that up. You go to the film and look at that film, that probably looks like the wedge is open on the left-hand side. See? And so first we'll find the subluxation on that right-hand side, and then go to the film and come up with a listing like a PRI-T. See, that indicates a wedge on the left-hand side. The PRI-T indicates that there's a wedge on the left-hand side, but our subluxation's on the right. So it's really not a wedge over there. What it is that it's inferior on the side that I'm going to adjust. that would be one that we'd want to add more lift than perhaps some of the other ones. See, question I would ask all of you, whether you're doctors now, or whether you're pretty quick to be doctors, or whether you're working on just even getting listings off people right now. How many times out of 100 do you use a wedge listing? I don't have the Jeopardy theme song, but we should just let it play for just a bit while you think about this. Because all too often you find that the doctors, that's all they ever use. PRS, PLS, PLI-T, and PRI-T, the 4 wedge listings. Because we have a concept in our head that if the nucleus has come to that side, it's got to lift it up, right? No, not at all. Not at all. If the nucleus has been there if it's not acute, it'll be lower. And if it's been there a long time, it's even lower. It's even lower. Again, going back to Dr. Gonstead on his tape, the tape he made the last week before he passed away was at his house. And Rod was there, T was there, Dr. Trox was there, Rod Campbell was there, Phyllis was there. I think who else was there. There's a few others on that tape. And they wanted him to take and go from A to Z on a patient, just all the stuff, because they wanted to get it all down on, they've had it on camera and on video many times, but they said, let's just go from A to Z on a patient here and you tell what it is. He said, well, this girl here, he's checking somebody, and he says that, see here, fellas, this is 6 cervical here, and he said, see here, fellas, he said that nucleus is laying over on that right-hand side, and he said that could be a PR, or that could be a PL-T, depending on the rotation and that. And Rod Campbell, who's always the genius that asks the right questions on these tapes, says, well, is there a wedge on that listing? And he said, well, it doesn't have to be. He said, I haven't checked that. He said, sometimes there is, and sometimes there isn't. And I could tell, you could tell that the wheels have turned. Well, the nucleus is on that side. Shouldn't it be wedged? Well, no, not every time, or not. It's not always a wedge. And you could tell that they're thinking that once the nucleus shifts that way, it's got to lift it up on that side, because the chapters actually promotes that thing. Page 54, and it's really not that way. It does lift it up sometimes, and sometimes we've got an inferior. There's all kinds of variety, and so again, when I say find the spot and list that spot, and make sure it's a listing that is for that spot. Don't list something that's on the other side, because you found it on the right-hand side. Don't let anybody change that. Don't let anybody change. Once you find that, you stick with that.
Hey, Doc, can I ask you for some clarification on that? What about if that spot is in the middle of the concavity of scoliosis?
That's a great question. I still contact that spot. Now, how do you correct that in comparison with what you're going to look at from an overall global picture of an X-ray that's got a bend in it? You have to correct that in relation to that. You can't, like if you're on the inside of if we're talking about scoliosis like this, or, depending on varying degrees. If you're on the inside of something that's like that, you can't be on the inside of that thing torquing that down. You can't be on the inside of that thing pushing it this way. All of that makes it work. If you're on the inside of this and you got one here, you got to pull that this way. That's got to come this way. The laterality is to that side. It's the same situation that he did on that tape before. The subluxation is on the inside. The laterality is the other way. And you have to correct that in accordance with making sure that you don't make that scoliosis worse. So in that instance there, our thought process about torquing that down would make that worse. Or even pushing that across would make that worse. If you're going to correct something that's on the side, that has to come this way. Okay. And I would say I never go away from where I find the subluxation and adjust something different, but it's really rare. It's really rare. It's only when you really have to have some kind of mechanical leverage that's different. And there are instances, but don't be afraid. Don't be afraid to do whatever it is that they need. So I know, again, they don't give me the secret handshake anymore when I talk like this. So they kicked me out of the club a long time ago. So. But I want to be right with that subluxation.
Okay. How do we set up a contact
questions
so
are all
that we do not increase that scoliosis? How do we set up a contact to prevent increase in that scoliosis?
You do it with your favorite hand. And your favorite hand in any adjustment is always your stabilization. It's always the best one. The adjusting hand has a real boring job most of the time. But the stabilization hand gets all kinds of fun things to do. So in that instance there, you would do it the same as if you're going to, if the bend was the other way. Think of it being on the high side of the rainbow. If you're going to stabilize that, let's say it's in the cervicals, and you stabilize that, you want to make sure that you're going to take and move that in a way that changes that for the better. And Dr. Gonstead called that getting it ready for setting. You get it ready for setting. And that has to do with all the things that you're going to do to get that in a position that's going to correct that. The same thing, you stop and think about it, you do the same thing when it's on the inside of that curve. Your stabilization hand, which you can put on the other side, you can take some of that out just like that and then set that through there. So in fact, it makes the adjustment so easy. There's times like I used to watch Dr. Troxon, he'd adjust with thumb. You know, lumbars. He'd have a lumbar in the knee chest and put a thumb on it. Like, what the heck do you do that? I mean, I'm like jumping from the ceiling trying to get one and move on the knee chest. And he says it's all about getting it ready for setting. Once it's ready for setting, it doesn't take anything. You get that at an angle that's just about what it is you get it so that it sneaks up to the edge of the cliff and the toes are hanging over, and then it only takes the adjusting hand just a little tap and it goes. So you have to bring that up to a point where it's getting ready or it gets ready to set. And once it gets there, it takes almost nothing to do it. And it's your stabilization hand. Your stabilization hand has so many more angles than it does. And all kinds of special things, especially in the cervical. There's nowhere else that we can actually wrap our hands around the entire family in the cervicals. And we can fix those. Dr. Gonstead did. I moved a chiropractic ahead 100 years with his analysis in the pelvis and the mechanics that he understood there. But his work in the cervical chair far surpasses that. We're so far ahead. Gonstead people are so far ahead, and I'm a hack at doing it. And we're so far ahead of anything else being done to cervicals. You can do anything you want. When we went out to Hawaii, I had a picture that my son Michael had from the clinic. And it was literally a forced cervical that was literally that far over the front of the fifth. It was more than halfway over the front of the fifth. And how do you correct them? Most of the people would say, I'm scared to death of that. I can't do that. Well, in that instance there, you contact the fifth, the subluxation's on the fifth. You contact the fifth, and you pull your stabilization hand, pulls that clear back like that. And all you got to do is just barely move that finger, and that thing sets. Because you brought it back to a point where it's ready to set. Not at end range. You don't take it to final, it won't go any further. You're not doing that. You take the pressure off that just enough, and you move that finger, and it sets that. And his picture was one of the clearest I'd ever seen. I used that when I went to Hawaii, and we were teaching in Hawaii. It was just a really great example of how you can fix anything at any angle. If you saw how far it was, you think that the posterior joints must be hooked over the top of it. The ones below. No. But you can, it's your stabilization hand that really fix it.
Dr. O'Hara, what did he do with the stabilization hand, you said? I'm trying to envision what the stabilization hand did for that spondy at 4 or whatever it was.
You contact, you got your left hand here, all on here. You got your left hand here. And before you adjust that, you drag that thing back like that. All you gotta do is have the film up on the view box and look over there and see what it's doing. You need to tip that back about that far. And then you set that. And it's the tiniest little thing. This is almost nothing to it. In fact, it amazes you how easy it is. Because we look at them and think, oh, don't do that. It's once it's ready for setting, it takes nothing. And that's what T was trying to tell me on the chest. He said, once you get it ready to set, you just move your thumb. And boom, off it goes. It's like, I don't know how to do that. It's all in getting it ready. You get it ready for setting. Whether it's halfway off the front end or whatever it is. You just get it ready.
I know it may be hard to describe over a meeting like this, but what are some key things that you're looking for to get that vertebra ready for setting? Like, is there a certain thing you're trying to feel? I know it's hard without actually doing it right now, but is there any cues that you're trying to feel for?
It's just feel. It's just feel. And I don't get them right. Geez, I didn't adjust like I want to. The next time I think I better bend it a little further, or next time I'm going to add just a little bit more of this or that. Write a note to yourself, because when it lets go, when it's really right, it's just a feel. You just lean into it, and if you lean into it and move, it slides right forward with you. That's not the one that needs to be adjusted. The one you lean into, whether it's your chest or whether it's a chair or wherever you happen to be, once you put some pressure against that, it will be resistant or restricted at that angle. See? So, and another thought, if you're writing stuff down, excuse me, I'm gonna spread some COVID on my screen. You wanna always think about not adjusting at end range. It's very painful to adjust at end range, and that's where you see so many techniques. Take it to its end range and then crack it. Take it to its end range and then crack it. Gonstead adjustment is never at end range. It's at the very beginning. All of our adjustments are made at the very beginning of the movement. So if it doesn't flex, you bring it forward just partway in flexion and then set it. You're not taking it down to flexion and trying to set it from there. Because the fixation is at the very beginning. It's at the beginning of the movement, so you adjust at the beginning of the movement. That will make it immensely easier for you. When you stop, it won't hurt you. Never hurts. Never hurts. I always tell them, nobody's ever said ouch. And then they really, you sure? It's like,
I think the biggest problem is
only if I've done it wrong.
We're practicing on students that don't really have, I don't think, true subluxations, and we're practicing on probable compensations or things that aren't subluxation. So we're getting a false feel for it right now, but we're working.
Yes, you are. Yes, you are. It's immensely easier when you get in practice. It's like, good Lord, this is easy to find. Because you're adjusting on each other where you've had 15 different vertebrae adjustments, like, oh, what a mess. You will get that when you get somebody come from someone else. Somebody come in, and that happens. There's a lot. Probably half the people in my town are that way. And supine twist in both ways, And it doesn't matter whether you got a headache or low back pain. You get the same thing from everybody. It's just, for everybody, and it's the same every time you go in. So you're gonna, when you have a patient that's come from there, it makes it much more complicated. And they got about half of them, all kinds of different techniques, and some of them are very specific. We got a couple upper cervical guys that are specific. They just don't mess with anybody's low back, which is kind of nice because somebody will drift in from their office and it's like, it's low back. it's like there's nothing complicated about it. You know, it hasn't been done. Yeah, you're gonna get all kinds of that. So, what about cases? I mean, what do we have for? I mean, are we mostly students here today, or are some doctors, or what are we at as far as like? What do you guys do for case management? What do you learn for case management?
The most part for our case management is trying to get through our sympathetic and parasympathetic subluxations understood, and really focusing mainly on that. And then the best case management practice that we really get is when we have a question or we have a patient, and then we ask Dr. Meisel about it, and then he'll show us in our pit normally. And that's the best way, I think, because it's in real time. And that's mainly how most of our case management's done. And then also Dr. Wood's boot camp, he has a whole case management booklet that he gives us to study. So that's a lot of our case management.
Oh, okay. That's good. That's good. Because even though when you're a student, sometimes you don't know what questions, because who's going to come in? You know, what kind of cases are we going to see? And so we talk about low backs and neck pains and headaches because we know we're going to see them, but we see everything. We see everything. You know, four out of every 10 patients in the United States are going to have Parkinson's at some time in their life. You know, and to think that they're not going to walk in our office is crazy. We get Parkinson's patients come in every day. You know, so there's all kinds of issues like that that we take care of, and they send more of their people that they know that have the same symptoms because they get better. And somebody comes in for some other issue and their Parkinson's smooths out, and it's like, what did you do? Well, you know, we help that. You know, we can help that. We can change that along. Sometimes you can change it and shake it off. So it just depends on, you know, that particular case. It just depends on that. But there's, as a student, it's like, how do I know it's going to walk in the office? I can just tell you everything. Everything's going to come in. And you learn from them, you know. What you're going to learn from them, what there is. And so there's different ways we handle things, you know, chiropractically, and probably each doctor handles it different. You know, Dr. Wood would be fantastic. Dr. Meisel, fantastic. You can get a chance to hear how they've taken care of these things because they've done a lot. You know, so that's what you need to have is that, and you learn a lot from each case. It's like, okay, what's the mechanism, and what does chiropractic do to change it? You know, what do we do as chiropractic to change it? And there's just no reason people wander around. But we talked about Tic Delarue up at our little circle there at the clinic. We talked about trifacial neuralgia. That week I had one come in that week. I had another one come in this week. It's like we should never talk about it because it's like that's what happens. So I get two different ones come in, and it's like, you know, we haven't talked about it, and I don't get a lot of those. I don't get a lot of those real often, you know, by the time it gets down the face or what it's doing. And so we happened to talk about that day. And lo and behold, we talked about not being in the jaw because of the way it's neurologically connected. I had a guy come in and had in his jaw. And I think that was like, somebody sent that to me because of what I just got done telling these people. It's like, you know, how are you going to take care of that? And, you know, because normally they're just the top two nerves that are involved, but this guy had one in the jaw. Yeah, he had the real deal, baby. I tell you what, it's hard to imagine the pain there until you're around him. It's like, oh, God, he couldn't breathe. He just couldn't breathe. He's a big guy, big tough looking guy, and it was killing him. So, but I thought that was. That's weird, you know. We just talked about it. I was telling you how when it's in the mandible, it's probably not on that. In his case, he had a jaw issue. Yeah.
Wow. Yeah, I mean, in our
those are the things that
they don't really. All of our case management is through our club with Dr. Meisel because a lot of our school doesn't really think too much about chiropractic doing much more than the general mechanical pain. So we are so lucky though, because we'll have a question and then Doc will give us like 3 different ways to look at it and think about it than we even came close to thinking about that. So that's how it's incredible.
Sure. And you can take, you think, oh, okay, what are we going to see? Low back, neck pain, and headache. And the school is going to teach you, because that's important. We'd like to think that's our bread and butter. But you can be anything you want to be in chiropractic. If you did nothing but take care of Parkinson's patients, you'd never get a vacation, because there's so many of them. They're all over the place. And what we offer to them, what we change on them is so different. It's so different than what they get medicated. There's just so many different ways to handle their case that we do different. Just even advising them on different things. And patient will send in somebody else they know that has it. He said, I don't know if you have any spinal problems, but I just want to hear what advice you give me. So there's all kinds of different things that we would do. We think of different. And part of that is we subtract the diagnosis. That's probably the first thing that you want to do when you're taking care of different cases, is subtract the diagnosis, because they'll come in, like the trigeminal neuralgia guy that came in that week after that. He's been to the doctor. They've been doing the MRIs, they've done the dye studies in the brain, they've been through the whole gamut of all this stuff, because he has trigeminal neuralgia, and they said, you can't think of it that way. You got to think of it. I got a nerve irritation. We have to change that. Diabetics the same way. You could, if you did nothing but just say, I'm going to take care of diabetics, you'd never get to home. You'd never get to home. You could lock your front door and turn off your lights, and they'll still find you, because what we do for them is so different. And I always tell a patient, they say, I'm diabetic. You can't count the number of patients come in and say that. I said, no, you don't. Your body just has trouble regulating sugar. Now let's see what we got to do to make it regulate sugar better. See? So you look at it from the standpoint, because that's what we do as chiropractors. We change the function. So they're going to give them insulin. Is it got anything to do with their pancreas? It might not. It could be a liver problem. It could be glycogen storage problem on the liver. Those diabetics always have higher sugar in the morning, which is opposite of what everything should be. And the medical doctor have all kinds of issues taking care of them. So you get people come in. One of the first things I ask if they're diabetic is, how have you been doing regulating? Because their doctor's been doing whatever they're regulating. And someone will say very well. I keep everything under control. It works very well. And then you'll have the others say, they've had me on 15 different things and different diets, and mine's never the same. And that's because it's not that their pancreas is not making enough insulin. If you can give them insulin, their pancreas, that's not the problem. It's a glycogen storage problem on the liver. And so their sugar's off because of that. And you have to address that. Sometimes it's chiropractic to that area, and sometimes it's people that, sometimes it's nutritional for a liver problem. So I'm not real big on the nutritional problems, but there's just other ways to approach it. So there's all kinds of different things that we do as chiropractors we change that function. We change the function of what we do.
So what did you notice the difference for higher sugar in the morning compared to just overall low blood sugar for or high blood sugar for diabetics overall? Did you find certain?
You should always see a pattern. Yeah, you should always see a pattern, because obviously the diabetic, the technical definition would be when they eat, their body cannot, the sugar can't enter the cell because of the insulin, lack of insulin. And so after they eat, their sugar should be the highest, right? Well, the longest time they go without eating is when they're sleeping at night. Well, how can they have high sugar in the morning? You know right away you got something different. It can't be that way. And that person will become what they call brittle diabetic, because the doctor just cannot get it correct. They've been on all kinds of doses. They wear the little thing now, on the arm. They wear that now to check their sugars. They're real good about getting their sugars checked all the time now, but they still have difficulty managing. And you just see a number of patients. First thing I ask them, your sugar's highest in the morning. Yeah, and then are you having an easy time, managing? And those people say no, they're just all screwed up.
Do those type of
Parkinson's, Parkinson's patients.
Do you see
What's that now? Say again?
Do you see those cases with high in the morning are more helpful with, like, chiropractic helps those type of cases very, very well as opposed to the other ones?
Yeah, absolutely. Because once they got the diagnosis of being diabetic, the medical doctor's gonna follow what the book says about how to take care of a diabetic. But they're not technically they're the same diabetic. And so we do much better with them. They do much better. They get your sugar down. Things work a lot better. If you want to check your liver enzymes, what would be the first thing that you think about if the liver was a function? It's 20th century problem. 21st century problem. What do we see? What's the next question you ask them besides liver enzymes? If it's thinking about the liver. What affects the liver? Cholesterol medication. They're all in fact, around our area here, for a while they brought them, they take all the people that were on statin drugs, and they were doing blood tests on them. And so I had patients come in and say, I got to go get my cholesterol checked, and they're going to check my liver enzymes. And they did that for about 6 months. And then they stopped doing it altogether because they were all coming positive. These people all had liver enzymes if they're taking statin drugs. In order for your body to stop making cholesterol, they got to kill the liver cell. That's what that drug does. So the statin drug does, it kills the liver cells. And so they'd have liver enzymes. And that's not only the number one issue in that, it's the number one issue in everything in the textbook that's autoimmune. If you look at if you take the chapters on autoimmune in the textbook and look at all the problems that are in that, that whole thick area, you open the rest of the book out and there's about this much autoimmune. And everything that's in there responds to cortisol. Everything that's in there does better on hydrocortisone. So your body makes cortisol, and Park Davis makes hydrocortisone. So, but that's again the first thing you want to do with any of them. Ask them, are they on cholesterol medication? Because the cholesterol medication kills off the liver. And why would they have high cholesterol? Some people eat junky diets, but that's rarely the cause. People are on statin drugs already know already. I can't eat 15 eggs a day and do all this stuff and eat bad stuff. So, how does that change? How does the statin drug? What does it do to drop the cholesterol? It kills the liver cells. But why is the liver producing more cholesterol? Because cholesterol is a chemical precursor for all of our steroids in the body, and that's in guidance. I get the page in guidance that I make a copy of, and as soon as somebody tells me they're on statin drugs, I say, "Here, go." I got that sitting right up there, and I grab a page out of there that I've got copies. And I say, "Go show your doctor this," because it's got all of them, aldosterone, cortisol, everything is, all the corticosteroids in the body start out as cholesterol. And if you want to get somebody off cholesterol medication, I don't know how to do it for gals. But for guys, it's real easy because on that page is testosterone. And they're like, you mean this, my statin drugs is making me low in testosterone? Because they know how that affects them. And it's like, they don't want to have that effect at all. And so they're like, I choose not to take that anymore because I want that all to function right. So the first thing you want to do in somebody's cholesterol medication like that, you go have the liver enzymes checked. And if they have autoimmune problems, that's what you got to do. Any of the arthritic conditions, they're all in the autoimmune. MS, MS. You got to take these people are MS. They cannot take cholesterol medication. You got to get them off the cholesterol medication. So, as a chiropractor, we don't unprescribe anything. But I do it the other way around. So, take the sheet to the doctor and tell them you're having some of these other issues and these other things, and cholesterol medication might be wrong. So,
What sheet is that?
You always want to ask the question. Say again?
What sheet was that in guidance?
I'm sorry. It's at the office.
Do you remember what
Well,
chapter?
wait a minute, I got another one here.
It's okay. Do you remember what chapter it was?
I can tell you, I know it.
Okay.
I got another guy right here. I grab it. You want to wait? Play the Jeopardy song for a minute. I'm going to run the other room. I'll come back.
It's a great.
Okay. It's a whole page, so I shouldn't be able to miss it. I'll email it to you.
That's fine. Thank you so much.
Drop in an email. I thought maybe I could thumb through it. Yeah. It's a whole page in the 10th, and it's a whole page in the 11th. And then when you go back and look at the other editions of Guyton all the way back to 1, he had it in a spot about this big in all the other editions. But in the 10th and the 11th, he made it a whole page. So he must have thought it was more important. So I will email you that and you pass it around. And like I said, I copy it out of the 11th because the 10th is Saunders and it's a real tight binding. The 11th edition is done by a different manufacturer, different book printer, and it's a real loose binder. The back end is real loose and it fits on the copy machine better. So I do it on that one. But anyway, yeah, that page. That helps a lot. It helps a lot when we're trying to take care of patients, and they're doing it. And a lot of them have gotten off it already. They've gotten off it, and the doctor puts them back on, and they get off, and the doctor puts them back on. Because they really have all kinds of pains and aches when they're on it. Because it's stopping your body from making cortisol. Now, like I said, it's MS, all kinds of different issues that we see. And you need to advise about that. Other questions? What are you thinking about?
Does anyone else have any other questions? We don't want to take up too much of your time. I know it's you had a full day of work, and we appreciate you coming on. If anyone has any other questions, now would be a great time to either put in the chat or ask. And but we appreciate you coming on tonight for us, Dr. O'Hara. I know you're very busy.
No, I'm glad to do it. I really had a blast when I did up tomorrow. But I'm sorry I didn't get it hooked up right to start with. Sorry I didn't get it hooked up to start with. But we eventually did. So we're going on.
We had X-rays we were going over before, so it's fine. You don't have to worry about anything. We just appreciate you taking time to come over.
No, it's been my pleasure. It's been my pleasure. I feel kind of bad. I'm up here in Iowa, and you guys are down in Florida. It don't seem fair. I mean, you guys get to going to school in Florida. That's just like something's wrong with that. There's just something wrong. You need to be up in the cold Midwest at Palmer or something. You know? This Palmer, Florida idea it was a good idea on Palmer's part, that's for sure. So.
We had someone ask, when can we
you guys are real lucky.
Dr. O'Hara's seminar?
Oh, does that mean you're coming to Iowa? Is that what you're doing? Or?
We'll give you.
You guys all gonna ride to come up here?
We'll come. We'll do it.
Yeah. Wait, did you? All right. You can all sleep in my house. We'll find someplace. We'll find enough pelvic benches. Everybody can sleep on pelvic benches. Hey, I know what I got. I got a question for you guys. How many of you are? Let's see my push here. How many of you are in GCSS as student members of GCSS? Is anybody a student member of GCSS?
I am, and I think a few other people are in our club. I don't know if they're in this still right now. Steven is. Yeah, we have a few members that are in there. Okay,
here's my thing. Everybody that's not a GCSS member that was here tonight, you know who's here tonight. What is it? Is it $35 or something like that for a year? Make sure they all join.
I think it's like 15.
Yeah.
Is it?
It's something crazy low.
Is it? I know when we had the last board meeting. Is it? The last board meeting is like, just lower this to about, make it $1 just so everybody joins. But however many anybody wants to join, just I think it's $35, and if they're 10 or 15 of you or whatever they are. So if you round up the names of anybody that was here tonight, and if they want to get into student GCSS, I think that's a real good thing. It starts supporting our research, and that's if we don't support that in some way, we lose out a lot practically. So that'd be a real good idea. So anybody that's interested in doing that, just maybe send me an email. Do that. You guys have my email. Send me an email, and I'll make sure you guys get in. So we'll make sure that's done.
Yes, sir. I do have it.
Okay, see something on my thing.
Let's say, speaking of supporting the GCSS, the Amazon app has something where you can set up like something you want to donate to, and GCSS is on that, and I think GMI is on that. So like a portion of whatever you purchase is going to go towards that. So whoever doesn't have that, go to smile.amazon.com and select the GCSS charity, and you'll be able to donate to that way as well.
Yes, and everything. Think about all the stuff we buy on Amazon. I think they even got it set up on eBay now. They got some different things on eBay. So if you buy that, and they'll ask, do you want to donate $1 to GCSS or something? And that's pretty nice. That works out pretty darn good. So all that really counts. There's a lot of people work really hard to try to keep the organization going, and nobody makes a nickel off it. They all spend the money, flying to the seminars. It's a matter of, it's just a matter of joining. We all pitch in that way, and it really helps a lot. So that I just wanted to mention that if anybody wasn't, and if they need to be, just email me, and I'll make sure you get in. You won't have to pay. I'll make sure it's taken care of. So we'll do that.
Thank you, Dr.
What time you guys got to be at school tomorrow?
We have a 7:30 full day. We start.
Oh. Oh, no. You want a note? I can give you a note. You guys know.
That'll be the best doctor's note right there. But thank you again. Yeah. And I'll also send this out to everyone in our club. We have a Facebook group of we have a lot of people in our Facebook group for our school club, and we have a lot of social media presence. So we'll also send that out about joining the GCSS to make sure students are aware of it. I think that might be the biggest thing. It's just not a lot of people are aware of it, and we'll definitely get the word out about it.
Yeah. Okay. Sure appreciate that. That's good. Thank you. Thank you very much. And thank all of you. This is fun for me. Like I said, I think I'd have the computer part easier next time if we try it again. So just let me know if you want to, and I'll be available. All right?
That's amazing. Thank you so much, Dr. O'Hara.
Thank you, Denny. Sure appreciate you. Thank you.
Oh, hey, take good care there, Dr. Scotty.
Say hi to
I'll
Julie.
see you soon.
Yep.
Thanks a bunch.
I will do that. Yes, indeed. I'll run.
That was awesome. Thank you, Doc.
Oh, you're welcome. You're welcome. Very nice. We'll see you again. We'll see you again soon, hopefully. So,
Yes, we plan to go up to the public bench seminar.
Oh, I'm gonna do 3-on-1s. I volunteered to do 3-on-1s up there. So
We're going to get there early to make sure you see it. But
okay, we'll count on that.
well, thank you again so much. And if you want to sign off, all you have to do is press that red button on the bottom with the white phone, and then that'll sign you off, okay?
Yeah, the red one?
Yep.
Oh, okay, very good. Well, thanks again. You guys take it easy now, all right?
Thank you so much, Dr. O'Hara.
That was great. That was awesome.
Good meeting, huh?
Yeah.
He's so smart. I feel like I need to.
What did you learn, Dr. Meisel?
What did I learn?
Yeah.
I
You
learned a few
something, we all
things.
need to know it.
The stuff about the cholesterol in the liver and blood sugar.
Okay.
Did you notice that too? Now that you hear him talk about how in the morning that blood sugar. Did you ever ask that question? Or
Well, I know my father is that way, but he likes to eat carbs before he goes to bed. So I think that's a different situation.
But that'd be an important question to ask, probably then, right? Is maybe what are you eating in the last probably 3 hours before you go to bed or something?
When's your last meal? Are you eating at 6 o'clock and you're done, or are you eating at 11:30 at night? You know, so or are you doing both?
Sure.
So.
yeah, it's funny.
Yeah, because one of the problems with the insulin is, you know, I mean, it works. So diabetics kind of have the attitude, and my dad's this way. Well, if it's high, I'll just take more insulin, or if it's low, I'll just eat more carbs. Yeah, he's my dad. What do I do?
Did you? So, what were your? I thought this would be cool to follow up with. I know it's getting late, but with Brittany's case, with the so how we took the X-ray and then they didn't find anything significant for at least a rib fracture. So
that's good, right? That's a good non-finding. We were worried about that.
Mm-hmm. So
let's adjust it.
So I said.
So let's adjust it.
So let's adjust it, yeah. Well, you know, I haven't scoped it, and you know whether the BB on the X-ray is a great idea that they did that, but it apparently isn't matching where her pain is.
They didn't really. They just put it there. They were like, "Where's your pain?" And I like felt my finger like where I was putting it, and then she just kind of like touched my back and then put it like far away from my finger. I don't know if she put it that lateral to like try and like avoid, because I said my pain was closer to the spine. So I didn't know if she thought like it was going to be in the way or what, but like she wasn't very like specific on trying to find exactly where the pain was, I feel like.
So, you know, one way to think would be, well, they don't want to put the BB on the point of pain because it could cover up the fracture, right?
Right.
But if you have the patient show you the point of pain, you know what rib it is, then put the BB, you know, on the rib but away from the point of pain, so at least you can trace it back to the rib.
Right.
Right? Yeah.
So I just didn't know. I thought it was pretty interesting and cool the way you said that we should go about it. If you want to just kind of tell everyone a little bit where you would think we should go, because this is like the first case where, at least for us, I don't know about anyone else, but it seemed like with a rib injury that isn't. So how to deal with that?
Well, like Denny he touched on it a little bit too. He said one of the hardest things is to try to unravel somebody else's mistake, right? And then when there's like 3 or 4 people intervening in the middle of a mistake, that's even harder, right? So that's why in Brittany's case, I was thinking, listen, we just need to, number one, rule out a fracture. And then number 2, we need to leave it alone, let it heal, find out how much of it is soft tissue. And then when it calms down, then we can, as long as it's clear, then we can start adjusting it. But then just one person and, on the right table. I wanted to ask Danny, and I thought of the question and I forgot about it, how many ribs he adjusted in practice. And I'd be curious, he'd say, I'm going to say not many, right? We just don't want to adjust them because we're not on them, right? We're just not on them. So, and if you adjust the vertebrae, the rib should go with the vertebrae, in a normal situation. So initially, because of all of the inflammation and swelling and the pounding that she took, we said just ice, right? But then, we've done that. You did ice for 3 days?
Yeah.
Yeah.
A little bit over the weekend too.
Okay, then we ruled out the fractures. So you were asking me now, you were asking me, well, now can we adjust? I thought, well, you could, but then I wanted to find out how much of it was in the soft tissue, the intercostal muscles, or, is it actually the vertebrae? But they never moved the vertebrae, right? It never got moved.
No.
Right, so they just kept pounding on your rib cage.
Right.
Yeah, so that's why I told you to, even though we're in the sympathetic area of the spine, if it's in the ribs between, but in the muscles, the intercostal muscles, then let's try some heat to see what that does. Does that make it better or does that make it worse? If it makes it better, then you know that their nerve root probably isn't involved because the heat's not making it swell. And muscles tend to respond to heat, right? They tend to calm down with increased blood flow and clean out the debris from the sprain. So have you used heat today or yesterday?
No.
Not yet? Okay. And I would use moist heat too, not dry heat, but moist heat. 10 minutes or so, maybe 3 times a day.
Okay.
And your pain is it over the spine or is it out over the ribs?
It's not over the spinous process, but it's definitely more over
it's like right on the transverse.
Yeah.
Okay, so it could be where about where the rib head is. So as long as don't put the heat right on the spine. Let's not heat up the nerve root, but let's get out on the rib and just see what that does.
Okay.
And if that really calms it down for you, then and improves your motion, then that there's some intercostal spraining that went on with that whole event.
Okay.
But just now when you adjust it, you're going to want to adjust it, real easy, real specific, on the right table.
And just like we were doing before with the thumb over pisiform contact.
Yeah, we had, because this is your second injury.
Yes.
Right? And so after the first one, I kind of got involved with it way at the end. You were out of the acute phase, but you were still having trouble, like when you sneezed, you get that really sharp grabbing pain.
Mm-hmm.
And I think it was T10 is where we found it, wasn't it?
Yeah, it was lower.
And so in that transition area there, the disc was open in the front on the one above. I'm sorry, it's open in the back on the one above and in the back on the one below.
Yes.
Mm-hmm.
Right? So, you can't lift that up. You have to lift it up enough to start it up the facet, but then you got to just come straight forward with it. And you were doing that and it was working out pretty good, right?
It was getting a lot better with that.
Yeah. It was just a nice, easy set, not getting too deep, just, getting it to heal. And for whatever reason, you'd let somebody else jump into that.
So it's hard to say no. I feel bad.
I know, because you want to reciprocate, right? Yeah.
No, I don't. But
yeah.
I just feel bad. Like I feel.
Because I didn't say this to you, but I don't want it to be. They're rare, but they happen, which would be a herniated thoracic disc.
Right.
They're pretty rare, but they can happen, and they're going to happen with stuff like that.
Right.
Yeah, because now the sneezes are even like she needs a minute to relax after a sneeze because she's in so much pain. It's incredible.
Yeah.
I've never seen that before.
Yeah. And you can't wrap it. Wrapping it, just that compression just makes it worse.
Yes.
Right? Yeah. You can't wrap them. You can't, so that's why you've got to be smart with them, not over-treat them, and just go easy on it. Go easy. Let it heal.
Yeah.
So, huh?
He said, "Thank you so much for."
Oh, you're welcome. I wish I could help you more.
Me too.